So we will come to the next case, and this is the guideline directed medical therapy for heart failure. This is what it will be. So this was a 75-year-old male with past history of non-ischemic cardiomyopathy. So already we know that patient has got cardiomyopathy 4 years back with risk factors of hypertension, past smoker, and patient has developed CKD stage 3A. So some degree of CKD is also present. If you look at vitals, blood pressure is 110/80, pulse rate is 110 per minute, irregular, respiratory rate 20, and SpO2 92 on room air. So now anybody, is these vitals okay? Any problem? Okay. So there is tachycardia, pulse is irregular. Anything else? That is also low. So anything else? Narrow pulse pressure. So obviously there is some hemodynamic compromise and it is getting compensated, and patient has also developed irregular. What kind of rhythms can happen? One is regular, one is sinus tachycardia. Commonest cause of sinus tachycardia? Fever, anemia, exercise, basically physiological causes. Pathological causes, what can be cause of sinus tachycardia? Pathological causes? That is rare, yes. Hyperthyroidism one. More common than hyperthyroidism. Pathological cause more common than hyperthyroidism. Hypovolemia, yes, cardiac cause, but yes, but more important. So if you see a patient of sinus tachycardia in your OPD and there is no physiological problem, anxiety, okay, but that is a problem, no? Fever to ho gaya na, no other physiological problem. So what is the commonest cause? It will be lung disease. Always remember this age group, 75-year-old, sinus tachycardia, nothing else found, start thinking of lung disease. That is the common cause. You have to rule out the hyperthyroidism, but which is not very common, as you know. Hypothyroidism is much more common. Hyperthyroidism is not that common. What we do see is some thyroiditis going into hypothyroidism, but at this age unlikely hyperthyroiditis leading into hypothyroidism. So more common cause would be lung disease. So sinus tachycardia, pathological cause, more common cause lung disease, but you have to rule out thyroid diseases. So that is one. So that is sinus tachycardia. Sinus bradycardia, what is the commonest cause? Athletes, yes. So there can be physiological causes. Some people can have a rate which is like this, but especially in athletes, you can have sinus bradycardia. But what could be pathological causes of sinus bradycardia?
Inflammatory disease like TB.
TB.
Tuberculosis, extrapulmonary tuberculosis.
Means TB affecting heart, very rare. Think of always, you know, you are in medicine. When you talk of causes, you have to say which is the commonest and then go down to rarest cause. So sinus bradycardia, commonest cause, very right, athlete is good, but other than that, what could be causes? Sleep, then it's not bradycardia, no? What is definition of tachycardia or bradycardia? But in waking condition or sleep condition? Awake condition. So already, you know, sleep, there will be some bradycardia. So we are not talking of sleep. So if there is lot of sinus bradycardia, the commonest cause would be drugs. And what is the drug that can cause? Most commonly beta blocker. So always think if somebody is on drugs, especially antihypertensive, they might be taking beta blockers. For some other reason, they can be taking beta blockers. So this is the commonest cause of sinus bradycardia. Okay, this is sinus. Now come to let us say tachycardia. Okay, and what can be causes of tachycardia? Tachycardia can be supraventricular, ventricular tachycardia. What are the causes of supraventricular tachycardia? AF and PSVT. Which is the commonest arrhythmia? AF. So, AF first, you should not say PSVT first and then talk of AF. Always remember, when you are asked to enumerate cause in medicine, you have to come from the most common to least common. Never say least common cause first. Then you will be asked more, then you come down to rare causes, but always say the commonest cause first. So, AF and okay, and now the question is whether tachycardia is regularly irregular, or irregularly irregular. Sinus tachycardia we already saw, but regularly irregular, what is the cause? Type 2 block, but one more, type 2 block will cause bradycardia, no, most likely. Why will it cause tachycardia? So, I am saying regularly irregular, yeah, tachycardia. So, what is the cause? BPC will be irregularly irregular. Atrial ectopic will be irregularly irregular. Regularly irregular, what it means? Atrial flutter, regularly irregular. Then third variety is irregularly irregular. What is the commonest cause? Atrial fibrillation. So, once we are talking of irregularly irregular, we are talking of irregularly regular. Irregularly irregular is AF. Maybe we are giving hint that it could be atrial flutter. Okay. So, obviously, there is some rate problem that is causing maybe this hemodynamic compromise, slight bit of hemodynamic compromise, and because respiratory rate is also high and SpO2 is also high. So, let us go to examination. So, on examination, a diffuse sustained laterally displaced apical impulse is present. What does this mean? Sustained diffuse laterally displaced impulse. What it means? Cardiomegaly, right ventricular type, LV type. And what type of LV load it is talking of? Volume will be pressure overload. Basically, sustained means pressure overload, but late stages of volume overload can also lead to sort of sustained impulse also. So, but once you say ill sustained, then you mean volume overload, either very long standing volume overload or a pressure overload. So, what is the cause of pressure overload in left ventricle? Commonest cause of pressure overload on left ventricle? Hypertension is the commonest cause probably, but then second one more classical is aortic stenosis. So, these are the causes of pressure overload. What is the cause of volume overload? Commonest cause of volume overload? Yeah, possible, most likely anemia, but then it will not cause that much volume overload that you can see. So, this kind of volume overload unlikely with anemia, but here you either think of AR, not MR, AR, that will cause more volume overload, because MR will also cause some, but not that much. But because why will it not cause that much volume overload? Why AR will cause more volume overload? Because at high pressure volume overload will happen, no? Because diastolic is also high, systolic is also high, diastolic is going down, so lot of gradient is available. So, anyway, more volume overload happens with regurgitant lesions, AR, but other than AR, what can be cause of volume overload? Early failure. Late failure will cause sustained impulse, but early failure can cause volume overload picture also, present like volume overload. So, it will, because LV will get dilated, so obviously more volume, so volume overload. S3 and S4 is present. What does this mean now? Presence of S3 means volume overload, and presence of S4 means? So, both pressure and volume overload means like advanced left sided failure. So, serious kind of LV failure will have this kind of picture, S3 and S4 both palpable. Accentuated P2. What does accentuated P2 mean? pH, because of left sided pressure. So, what it means is that probably it has been a sustained left ventricular failure that has led to development of pH also. So, what it tells you about failure, number one, that it looks like maybe an advanced kind of failure, number one. Number two, what it tells you is that it has been there for some time. So, whatever we are seeing tells us that maybe it is present for some time. Anyway, if apical impulse is laterally shifted, then it has to be some long standing failure. Otherwise, short standing will not get that much LV dilatation. So, this is the thing. Now, a pansystolic murmur is also present. What it tells you? You have to rule out a valve lesion, you have to rule out rheumatic heart disease, but basically it looks like all the picture fitting that LV has dilated. So, because of dilatation there is some MR. So, mitral regurgitation. Now, early inspiratory brachial crackles were present. So, what does that mean? Maybe patient is going into pulmonary edema, right? Then dullness to percussion and diminished breath sound in the lung basis. What it means? Pulmonary edema? Yes. Some pleural effusion. What effusion? Pleural effusion. Because diminished breath sounds at lung basis. Pulmonary edema will not cause this unless there is infusion. With pulmonary edema, effusion is very common. So, that is why this diminished breath sounds at lung basis. So, there is evidence of effusion, but CNS and GE was not contributory. So, next. So, what are the investigations that we take? Now, looks like what we have done only from examination and history we have made a diagnosis of long standing left ventricular failure, possibility of what is the possible cause of long standing left ventricular failure in this lady. She is a 75-year male or female, I forgot, male maybe, male patient. So, what is the cause for this long standing valvular? You did not pay attention, go back. Ischemic cardiomyopathy. Patient is already known case of ischemic cardiomyopathy. So, why bring valve in? Patient is already known case of ischemic cardiomyopathy. So, looks like that it has been going on for long and now patient has gone into failure which has been there for some time. So, ischemic cardiomyopathy is the cause. So, we already know that patient has got ischemic cardiomyopathy and has gone into kind of left ventricular failure. So, acute decompensated heart failure has happened on the top of ischemic cardiomyopathy which has led to this kind of picture. Clear? Everybody okay? So, we have to do some routine tests and we have to do some specific tests. So, depending on the case we decide routine test. Okay? So, X-ray you want to do? Yes. ECG you want to do? Echocardiography you want to do? RF2 you want to do? Why? CKD. Hemoglobin you want to do? Why? Anemia. And you can correct it. Sugar, HbA1c you want to do? You want to check whether diabetes is contributing to cardiomyopathy, because how many cases, suppose you see heart attack patients in India, for example, let us say you see heart attack patients in India or you see coronary artery disease patients in India. So, what is the prevalence of diabetes in whole CAD population? What is the prevalence? Anybody, any guess, wild guess, any guess? 50 is bit high, about 40%, 30 to 40% is about, at least 1/3 of them will have diabetes. So, whether obviously they must have done it before, but still you want to recheck whether diabetes is also present or not, because many times patient play, because diabetes does not cause those many symptoms. So, there are two diseases which do not cause that much symptom, that is why people do not want to take medications for them unless they start causing complications. So, what are those two diseases? Hypertension, diabetes. Hypertension, long time they will go asymptomatic, even if you diagnose hypertension they will not treat. When the hypertension this thing was founded first hypertension USA में actually hypertension was there for long, but people thought hypertension is good. There was one president who was FDR, Franklin D. Roosevelt. He had won 2 presidencies, and then he applied for 3rd presidency also. His doctor told him not to go for the 3rd term, FDR, because he said that the cardiologist, or at that time cardiology was not that well known. So, for FDR, you remember, was there at the time of World War. So, the people told him, some people told him, don't go for your presidency, we are not well. But the Surgeon General there, the main like we have DGHS, Director General Health Service, there USA it is called Surgeon General. So, Surgeon General at that time certified that FDR is in pink of health because his blood pressure is so good, and his blood pressure was, I think, 220 by 120, something like that. And he said because the blood pressure is so good, and so his heart must be so good that it is generating so much pressure, 220 by 120, that he is in pink of health. And in the 3rd term, within next 1 year or so, actually he died. So, then they realized that hypertension is a big problem. It is not pink of health, it is something is abnormal. And then they also started the rule in USA that nobody can go for presidency more than 2 terms. This was because of this episode, the FDR episode, that 3rd term he actually died within the term, and then it was a lot of problem, and somebody became the president who was the vice president, and they took up the charge of president. So, at that time they decided the 2 terms will not be given. Second, what they did was they founded this hypertension whole group, these guidelines, JNC, Joint National Commission. JNC, you have heard? JNC 1, JNC 2. So, JNC 1 was founded, and then they started, and then they thought, let us look at how many people have blood pressure in America, adult population. And what they found was that 50% of blood pressure people did not know they had blood pressure. So, they were asymptomatic. What number they found? They found that 50% did not know they had blood pressure. Out of the 50% who knew blood pressure, 50% were not taking any treatment. And out of the 50% who were taking treatment, only 50% were well controlled on blood pressure. So, which means that a huge population was not taking any treatment or not properly controlled. In India, after independence, they did a survey, and they found that only 9% of the population in India were taking proper medications. So, 91% of the Indians were not taking any proper medication, and now some recent surveys have come that 1 in 3 people in India have hypertension. So, these are some recent surveys. So, you can imagine, but how many people are taking blood pressure treatment? So, this is one area that is totally neglected. Likewise, diabetes is another area which is totally neglected, because it does not cause immediately symptoms. Unless you have very serious infection which is not getting treated, most people do not come to attention. So, these are 2 problems. That is why in most people, at least in India, because the prevalence is so high, that you do this diabetes test. Cardiac marker, you want to do troponin? Anybody? You want to do? Why? Cardiomyopathy, troponin will be normal. Also normal. Only in heart attack troponin will be raised. No, there has to be a myocardial damage, then troponin will get raised. Myocardial damage could be because of myocarditis, because of heart attack, because of drugs, because of anything, but that has to be myocardial damage, acute myocardial damage. So, why do troponin now? Anybody who has decompensated, you are not sure whether there is a silent acute coronary event or not. So, that is why you want to check troponin, because it could be non-QMI. So, ECG is normal, there could be non-QMI, you do not know unless you do troponin. That is the importance of biomarkers. So, as I said, now biomarkers are thing. So, that is why you want to do troponin here. You want to do anti-pro-BNP, BNP? Why? Yeah. So, could be because of respiratory problem also, you are not sure. Patient has cardiomyopathy, does not mean always will go into heart failure, could be some respiratory problem also at this age, sinus tachycardia, you do not know. So, you want to make sure clarify, if BNPs rise too much, then you can always make a diagnosis of heart failure. If BNP is borderline, then you are not sure, it won't help. Do you want to do coronary angiography? Anybody? Coronary angiography? You already know patient is ischemic heart disease, you already know patient is in heart failure. At this moment, doing coronary angiography without chest pain, patient has not presented with chest pain, right? Patient has presented with breathlessness. There is no history of chest pain. So, it is troponin, suppose we find, unless troponin is raised, maybe angiography is not indicated. Unless you see MI on ECG, acute MI, then maybe you do coronary angiography. If you do not see those changes, you may not want to do coronary angiography at this stage, especially in a sicker patient. If this patient did not have heart failure, suppose patient did not have heart failure, patient had just come like that, then maybe you want to do coronary angiography to make sure whether some artery is blocked or something. But here doing coronary angiography can be risky, because patient is already in LVF, you give contrast, fluid overload will increase, kidney damage can happen with contrast. So, patient can get sicker unless you clearly know that okay, I want to do bypass surgery for this patient. If you have that much an idea, then it is a different story, otherwise you do not push for coronary angiography at this stage. What do you say? Okay. MRI you want to do?
Yes.
Why?
To rule out heart function alveolar dimension.
Heart function dimension, echo.
If there is any myocarditis.
Myocarditis in this age 75 without fever. See, young age 15-year, I will agree completely. Here you know patient has got ischemic cardiomyopathy. We know that ischemic cardiomyopathy may progress with age. So, my idea is to understand, always do necessary tests. Why do unnecessary tests? When you already know patient has ischemic cardiomyopathy, when you already know this, suppose something new comes up, then you think, suppose there is a fever, and then you are not sure whether it is because of just progression of ischemic cardiomyopathy or whether it is new myocarditis happening. At this stage, myocarditis is also uncommon. If it is 15 years of age, I will agree with you completely. We can do this particular test, but at this age, then everything you know, patient is ischemic cardiomyopathy already know, then why you think of another possibility? For what reason? Thinking of acute coronary syndrome is still likely, but thinking of myocarditis in this age, bit odd. So, I will not do endomyocardial biopsy, will not do. We are not even doing MRI, then why do endomyocardial biopsy? And you take patient to Cath lab and put a something biopsy forceps, patient goes into further LVF and he crashes, then what is the sense, no? So, it is an invasive test. When MRI non-invasive you are not doing, why you want to do invasive test? Serological tests, not much benefit even in myocarditis here, anyway you are not thinking of myocarditis, maybe not. PET, why would you do a PET in this kind of patient of ischemic cardiomyopathy? To check the viability. Suppose you are thinking that this patient may benefit from surgery. So, in that case you can do a PET scan to see whether this is, but before that you will do angiography to find out whether something is graftable or not. Some PTCable is possible, is not. If it is not possible, then why waste money and also time and also this particular stress of doing PET. PET you will do if you think patient will benefit from bypass surgery. We are not thinking at the moment in that direction. Urine osmolality, I think we leave. Next. So, anyway you said we will do X-ray, we did X-ray, and what does X-ray show? Two things, cardiomegaly. What is definition of cardiomegaly? Definition of cardiomegaly on X-ray, anybody? CT ratio more than 50, not 60, 50. And how do you measure CT ratio? So, simple thing you do, you take this pen, you put it here, so it is like you can see double the pen or more than that. This is less than pen and this is also less than pen. So, obviously it is more than 50%. Simple thing you can do, you can take your pen and you can measure. So, if you can put one pen here and one pen there and between you can put two pens, then it is 50%. If it is this is less, then this is less, this is less, this is on exam you can very quickly tell whether cardiomegaly is present or not present. Okay, but here as you can see cardiomegaly, I would say about 60%, 65% must be there, and upper low pulmonary venous congestion. So what you see, there is something called bat wing appearance. What is bat wing? Like this. So if you see something like this and like this, here this is because overlapping, so like this and this. So if it becomes a bit more, then it will become like bat wing. So that is the evidence of pulmonary venous congestion. So upper lobe pulmonary venous congestion is present. Now to remember what you see in LVF, you remember this acronym A, B, C, D, E. A is alveolar edema, which you can see some kind of bat wing, dilated upper lobe vessels, which you can see here, curly B lines, which not seen here. Maybe why not seen here? Because patient we thought was in kind of pulmonary edema, but you must have given some treatment. By the time you do X-ray, already some of things get better. But here you see some lines, horizontal lines. I will show you some X-rays of curly B lines. So those are curly B lines. Cardiomegaly is present, upper lobe vessels are dilated, and there could be evidence of pleural effusion. Here some pleural effusion. So these are the things that you find in chest X-ray in patients of left ventricular failure. Next. Now this is ECG. What do you see on ECG? Now one thing I would say, that if patient has heart failure, very unlikely that ECG will be completely normal. That is very unlikely. If you see a normal ECG, then probably you should not make a diagnosis of left ventricular failure, because something will be abnormal. Most commonly there will be sinus tachycardia. We already know that there was tachycardia. Here what kind of tachycardia it is? We thought it could be atrial flutter, irregularly regular beat. So remember, we thought it was atrial flutter, but here sinus tachycardia. So there could be two things. Either our initial examination was not accurate, or there could be a what kind of atrial flutter? Could it be paroxysmal? So it could be paroxysmal atrial fibrillation, or could be paroxysmal atrial arrhythmias are quite likely. And when that happens, paroxysmal AF, suppose somebody has AF, a normal person, nothing is abnormal, so far as you know, and patient has AF. So what part of heart correlates with AF? Left atrium. So what is the left atrial size? That determines, if it is more than that, then most people start getting AF. If it is borderline, then AF will not happen, will sometimes happen, sometimes not happen. And if it is less than that, then mostly people don't have AF.
5.5 centimeters.
40, 4 is that size. At 4 to 4.5 will be borderline. After 4.5, most people will start getting AF. If LA dilatation, we are talking of LA dilatation. Okay. So about 40 LA dimension is the borderline. More than 40, people start getting AF. So if somebody has AF coming, going, maybe you think maybe LA could be around 40, because sometimes he has, sometimes doesn't have. If it is more than 50, 60, then most people will have persistent AF. If it is 45 or 50, then most people will have persistent AF. So AF gives you an idea of LA size also. That is important. So here, but there is sinus tachycardia. Is there LVH? What are the criteria for LVH? Did you attend the ECG class we organized? Some of you, or no? Nobody attended. So what are the criteria for LVH? What is that criteria? Sokolov criteria. So what is that criteria? So it is there or not there?
Yes,
V1 and here
V5, V6.
Here you see itself is like enough of the criteria. So LVH is present, right? Now what about left atrial abnormality? You think some left atrial enlargement is there? What is the criteria for left atrial enlargement? P pulmonale. So you think P pulmonale? Where do you see P pulmonale? P mitral suggests. P pulmonary suggests
Right atrial load.
right atrial overload. And so how do you check for P mitral?
Duration of P wave.
So what is the duration of P wave?
Only 2.
More than 2.5.
So it is there.
No.
What about the other criteria? V1. V1 is important.
Second component. P
Second component. So you see this thing, this down thing going. So it is like bifid wave. So this bifid wave is very sensitive sign for LA enlargement. So you see evidence of LA enlargement. Also we know that patient was developing atrial flutter, fibrillation, whatever. So already we think that I told you that maybe LA is borderline. Here you see clearly that patient has got LA enlargement. So this is just confirmed. So everything gets confirmed actually. Then there is some lateral STT abnormalities. So why these STT changes? LVH, okay. Any other thing?
Tachycardia induced.
Ischemia, LV,
Tachycardia induced, maybe, but
CKD,
CKD,
hypertension.
ischemia,
Yes, sir.
possible? Patient already has ischemic cardiomyopathy, so you are not surprised if some STT changes are present. Okay. And then QRS left deviation, what it means? How do you calculate the axis? So you have attended that class which I organized, I hope.
Lead 1 and lead AV.
Lead 1 and AV.
So what you see?
Lead 1 is positive.
Lead 1 and AVL, AVF, okay. So if both are positive, suppose this is positive, what it says? Normal. Suppose this is positive and this is negative, what it says? Left axis. And suppose this is negative and this is positive, then? So this is how you diagnose the deviation. So here what is the deviation? This is slightly more than this, so some left axis deviation. So evidence of left axis deviation. So as I said, ECG is a very reasonable screening test. It rules out many things, but it is a screening test. If it is not heart failure, then ECG will be normal. If ECG is completely normal, then it practically rules out heart failure. Heart failure will have something, most likely sinus tachycardia at least, if not more. But other things can be present, as I said, presence of LVH, left atrial enlargement, also present of tachyarrhythmias, bradyarrhythmias. There could be tachyarrhythmias also. We know that there was some maybe atrial flutter. We have not seen that ECG, but possible based on just examination. And then it can also show us presence of past myocardial infarction and ischemia and coronary artery disease, which we think we can see here. Next. Now obviously the test of choice we already discussed was echocardiography. Here echocardiography showed ejection fraction of 30%, severe MR and moderate TR, but already undergone repair. Even after that, then this repair has happened, but the patient has presented with worsening dyspnea at this time. So question is whether it is heart failure with reduced ejection fraction. Obviously it is reduced ejection fraction 30%. The only question left is whether it is heart failure. So heart failure is also there. There are clinical features, edema, worsening dyspnea we have. So this is one of the features. X-ray shows congestion. ECG shows sinus tachycardia with some STT changes, left ventricular hypertrophy, left atrial enlargement. So that is also consistent, and more importantly, TT is showing an ejection fraction of 30%. Of course, biomarkers are very important, and you can do Cath, etc., but biomarkers are there. Unfortunately, in this patient, the biomarker report got misplaced, so we don't have the exact value, but they were done, and we were told that they were quite high. So now question is, how do you treat? Now this class is on treatment actually. This part is just to make the diagnosis, talk about other things, but how do you treat heart failure with reduced ejection fraction? So number one thing is, of course, you find a treatable cause for heart failure. Here the cause is ischemic cardiomyopathy. So you probably have already treated ischemia, and already repair has been done. So obviously if there is something bypassable also, they would have put a graft. Maybe it is end stage heart disease, nothing can be bypassed, but they have done repair of mitral valve. So the treatment has been done so far as we know. Now the question that remains is this guideline directed medical therapy. patient has presented with decompensated heart failure, managing that decompensated heart failure. If required now, because it is a progressive heart failure, so whether a cardiac assist device is required or not, cardiac transplantation is required. This we discussed last time also, but the same things happen. But my focus this time was on the guideline directed medical therapy. I wanted to show you what is guideline directed medical therapy. So as I said, guideline directed medical therapy has been developed to first of all improve the prognosis and improve the quality of life for the heart failure patients. So it may improve mortality or decrease mortality, it may improve quality of life. So in heart failure there are two kinds of drugs. One group of drugs improve mortality, other groups of drugs improve symptoms. So there are some drugs which improve symptom, but they don't improve mortality. And what are those drugs? Diuretics, number one. Diuretics means non-MRA diuretics. Non-MRA diuretics. So it could be thiazide diuretics, loop diuretics. So diuretics is one group of drug that can improve symptoms, but may not improve mortality. Any other group of drug? Digoxin. Digoxin may improve symptoms, but actually is very dangerous drug to give. Why? Toxicity is one, but I think more important thing is once you put on digoxin, you cannot take off. And so many complications, and once you put on digoxin, then probably you cannot take it. What trial? What trial showed that digoxin is maybe not that much helpful in heart failure, especially not improving mortality, rather maybe could be worsening mortality. What trial? DIG trial. Kisne bola? DIG trial. DIG trial. Remember, this is very classical trial. DIG trial showed that maybe because before that everybody was put on digoxin. But then this trial showed that maybe it is not very good idea to give even digitalis. So now today, in today's date, what is the indication for digitalis? What is the indication of digitalis?
Patient with LVEF less than 40% in CHF. EF less than 40%.
So this is the patient, then we should start digitalis?
Yes, sir. Indication.
There are sorry. Yes, that is the indication. So suppose somebody has got atrial fibrillation which is not getting controlled on, let us say, what is the first drug you will use in atrial fibrillation with fast ventricular rate? So you do two things. There are two approaches. If you have AF with fast ventricular rate, there are two approaches. What are the two approaches? Rhythm control and rate control. So rhythm control, what is the idea of rhythm control? Rhythm control you do when you think LA size is not large. That time you try to revert AF into normal sinus rhythm by, one is drugs. Which group of drugs? CCB. Amiodarone. Rhythm control. You can give amiodarone. So that is what class of antiarrhythmic agent? 3. So that means what I am telling you need to go and read that. So there are 4 classes of antiarrhythmics. Class 1, what is class 1?
Class 1 is sodium.
Sodium channel. What drugs?
Yes, sir. Quinidine, procainamide, disopyramide, QPTs.
Class 2?
Maxilitine.
Lidocaine कहाँ है?
No, not lidocaine. Maxilitine is class 2.
Lidocaine कहाँ है?
Lidocaine class 3.
Lidocaine.
3D.
And 3 is? Okay, I think best is go and read because this is important. At least you should know class 1 drugs, class 2 drugs, class 3 drugs, class 4 drugs. What are class 4 drugs? Beta blockers. So these are 4 classes of antiarrhythmic agents. They are used in different situations. You cannot use when class 1 is required, you cannot use class 4. When class 4 is required, you cannot use class 3 and so on. Sometimes you can interchange, but they have their different mechanism of actions and they have got their different roles, right. So digitalis, I think one of the thing is this, what he said, AF with fast ventricular rate, that is one indication in current age. The other indication could be a resistant heart failure, not responding to any drug, then maybe as a line 3 therapy, something like that, you can start digitalis. So something like that. So digitalis is another drug which does not improve mortality, and which trial is that trial which showed it does not. Any other drug that can improve symptoms in heart failure sometimes, but because one problem in heart failure is congestion, and any other decongestive agent you can use vasodilators. That can also help in decongestion. Nitrates also some people use if there is not a lot of tachycardia, people can use nitrates. NTG you give infusions, no, in heart failure. Sometimes when pulmonary edema is there, you can give NTG infusion. So vasodilator, nitrates, but it does not improve mortality. It may temporarily improve symptoms. But what are the drugs that improve mortality? Improve mortality, but do not improve symptoms. Beta blockers. Improve mortality, but do not improve symptoms, but can worsen symptoms. That is beta blockers. Then there are certain group of drugs that improve mortality and improve symptoms also. ACE inhibitors, ARBs, ARNI, MRAs, mineralocorticoid receptor antagonists. So you have to clearly think of these 3 group of drugs. So group 1 drugs will be those which improve mortality basically. So obviously first one is beta blocker. And what beta blockers have been tried in heart failure? Nebivolol has been, you give nebivolol? You know what is nebivolol? What? What is the advantage of nebivolol? A new drug है, but tried है in heart failure? Not tried. Only 3 group of drugs have been tried, and you need to know trials. So metoprolol, what is the trial name? Actually there are 10-20 trials that have been done on metoprolol, but at least name one trial on metoprolol. बोलो कार्डियोलॉजी वाले बताओ ट्रायल metoprolol की. मेरिट HF, Copernicus, कैप्रिकॉन, यस कैप्रिकॉन, ठीक है. और दूसरा carbidoll trials. Need to know these trials. Medicine and especially cardiology need to know these trials. And the third is bisoprolol. What trial? Cibis? Cibis. No? So bisoprolol. So these 3 drugs. Okay. Then as I said, ACE inhibitor, ARBs and ARNI. Any data with what ACE inhibitor? Enalapril, captopril? Tissue specific ACE inhibitor. What is tissue specific ACE inhibitor? बताओ, आप लोग तो बताओ कार्डियोलॉजी वाले, वो भी तो हैं उधर, बोलो. नहीं, कौन से होते हैं टिश्यू स्पेसिफिक एस इनहिबिटर्स? रेमिप्रिल, पेरिंडोप्रिल, है ना. सो डेटा इज विद दीज ड्रग्स इन इम्प्रूविंग मोर्टेलिटी. हाँ, पेरिंडोप्रिल इज जस्ट, yes, perindopril and ramipril. These 2 drugs have got a lot of data. And ARBs, some data. ARNI, what is the trial in heart failure? ये तो पढ़ो, आपके तो पास आ रहा है एग्जाम. ये सारी ट्रायल तो, ये तो बहुत क्लासिक ट्रायल्स हैं. मैं तो कोई ऐसी फालतू ट्रायल नहीं पूछ रहा. ये सारी क्लासिक ट्रायल्स हैं. ये तो मेडिसिन वालों से भी पूछ लेंगे. तो कार्डियोलॉजी वालों को तो आनी चाहिए ये ट्रायल्स. आर्नी की ट्रायल नहीं बताओगे आप, वो तो आपको घर भेज देगा. ठीक है, आर्नी की ट्रायल्स बताओ. फिर डायरेटिक, लूप डायरेटिक, इट इंप्रूव सिम्टम्स, नो इफेक्ट ऑन मोर्टेलिटी. थायजाइड्स, इंप्रूव सिम्टम्स, नो इफेक्ट ऑन मोर्टेलिटी. व्हाट आर द थायजाइड्स? व्हाट आर द थायजाइड्स? कौन से थायजाइड्स अवेलेबल हैं? एंड फ्यूरोसमाइड तो लूप डायरेटिक है. कौन सा मेडिसिन वाले ने बोला? इंडापामाइड. हाँ, बट मोर इम्पोर्टेंट इंडापामाइड. तुम्हें हाईवेट अच्छे से पड़ी हुई है. एक्चुअली क्या है कि ये यूरोपियन ड्रग है, इंडापामाइड और पेरिंडोप्रिल, they don't have, they are not used in America because for getting drugs into America you have to do very big studies, FDA approved studies, and it takes a lot of money. So many Europeans don't get their drugs approved in USA itself. So जो पेरिंडोप्रिल है या जो इंडापामाइड है, they are not approved in US so far, maybe they are just now, but अभी बहुत टाइम तक तो नहीं अप्रूव थी, इसलिए इतने ज़्यादा लोग जानते नहीं हैं. बट पेरिंडोप्रिल इज़ वन वेरी गुड ड्रग जो कि हमारे यहाँ अवेलेबल है, और इंडापामाइड इज माइल्ड डाययूरेटिक, सो इट इज़ नॉट वेरी गुड डाययूरेटिक, माइल्ड डाययूरेटिक विथ वेसोडाइलेटर इफेक्ट, सो दैट इज़ वाई इट इज़ वेरी यूजफुल in heart failure. So these are the diuretics that you can use. Loop diuretic, what are the classes? Furosemide and bumetanide and torsemide. What is the advantage of torsemide over furosemide? Medicine people, pehle medicine people. Which one do you use now? Do you Ditor or you use, पता नहीं Ditor use करते हैं कि नहीं, but you use torsemide or you use furosemide? Lasix use ज़्यादा करते हो कि Ditor ज़्यादा use करते हो? Ditor ज़्यादा use. Why? पता तो होना चाहिए, बस ऐसे ही क्यों यूज कर रहे हो आप torsemide over furosemide? Why? Why? एक तो डबल पोटेंसी है, जो torsemide is twice as strong as furosemide, so half dose of torsemide can do what furosemide does, but वो नहीं है important reason.
Causes less hypernatremia.
Maybe no. Basically furosemide is not very effective and there is gut edema. जब हार्ट फेलियर होता है तो गट एडिमा भी हो जाता है, तो फ्यूरोसेमाइड इज नॉट एब्जॉर्ब्ड वेल. सो आईवी तो फ्यूरोसेमाइड देते हैं, आईवी लैसिक्स देते हैं, लेकिन ओरल टॉर्सेमाइड देते हैं बिकॉज ऑफ प्रॉब्लम ऑफ गट एडिमा. गट एडिमा में टॉर्सेमाइड इज मोर इफेक्टिव देन फ्यूरोसेमाइड, दैट इज व्हाई वी यूज टॉर्सेमाइड. ओके, देन मिनरलोकॉर्टिकॉइड रिसेप्टर एंटागनिस्ट, इसमें दो हैं, स्पाइनोलेक्ट्रॉल, एप्रिलिनोल. सो do these drugs improve mortality? Okay, trial, spironolactone trial and eplerenone trial. eplerenone trial का नाम क्या है? ये तो पढ़ लो भाई ट्रायल्स, इसकी ये जो मैं बता रहा हूँ ये जरूर पढ़ लो ये ट्रायल्स, ठीक है. eplerenone की क्या ट्रायल है जिसने कि improve करी mortality? Then of course if it does not get, these are like first line. Beta blocker, ACE inhibitor, ARB or ARNI, diuretic mostly if there is congestion. If there is no congestion, you don't need to use, but most of the heart failure patients will have congestion, so you will have to use diuretic. Then MRAs, if doesn't benefit with this, then you go to MRA, add MRA if it's not benefiting. If not benefiting with all these, then you go for IC/DC/RTD. But one thing that is commonly forgotten is, what is the commonest cause of worsening of heart failure? Suppose there is a stable heart failure patient suddenly goes into acute decompensated heart failure. What is the commonest cause? Simple flu, pneumonia, something like that. That is why you do vaccination in those people, so that you can prevent this seasonal worsening of heart failure. So you do some vaccination. So flu vaccine and pneumonia vaccine. So how do you give flu vaccine? How many times you give flu vaccine? Every 3 year? No.
6 months.
6 month भी नहीं है, हर season yearly. And how many times you give pneumonia vaccination? Every 1 month, 6 months, 1 year, 5 year. Why you have to give vaccination again and again in influenza? स्ट्रेन चेंज हो जाता है. कोविड में क्या होता है? स्ट्रेन चेंज हो जाता है. कोविड RNA वायरस है, फटाफट चेंज होता है, तो 6 मंथ्स में भी हो सकता है ज़रूरत पड़ जाए, 9 मंथ्स में ज़रूरत पड़ जाए. सिर्फ फ्लू वायरस है, चेंज हो जाता है, लेकिन बैक्टीरिया इजीली डज नॉट चेंज. तो आपने एक बार बैक्टीरिया का वैक्सीनेशन दे दिया तो हो सकता है 5 साल चल जाए. सो ये रीज़न है, ठीक है ना. आप सब चीज़ को सोचा करो कि क्यों ऐसा हो रहा है. हम कोई चीज़ कुछ कर रहे हैं, हम तो बिल्कुल पागल तो नहीं है, तो वो क्या है रीज़न जिस वजह से ऐसा कर रहे हैं। तो फ्लू में चेंज होता रहता है वायरस, तो एवरी सीजन यू हैव टू गिव एंटी फ्लू वैक्सीन, बट जो चीज़ स्लोली म्यूटेट करती हैं उसमें मे बी यू कैन कीप अ लॉन्ग गैप। बाकी दिस न्यू ड्रग which is, as I said, diabetic drug but used in heart failure. What is the trial? Trial ये तो सबको पता है। डापा तो एक ट्रायल है, पहले तो कौन सी आई थी, एम्पाग्लिफ्लोजिन, उसकी कौन सी ट्रायल है? हाँ, एम्पा, चलो पढ़ के आना, ये सब चीज़ें इंपॉर्टेंट है, ये हार्ट फेलियर में इट्स वेरी इंपॉर्टेंट कि ये कुछ ट्रायल जो मैंने बताई हैं आनी चाहिए, ठीक है। नेक्स्ट, बट प्रॉब्लम इज दैट यू हैव टू यूज दिस, हाउ टू यूज दिस ड्रग्स, you know the group of drugs that work, you know group which improves mortality, you know group which improves symptoms, you know group which increase both mortality and symptoms, but how to use them. So this patient I will give you how to do it. So number one is, first is, suppose first of all start guideline directed medical therapy, which means you have to start ACE inhibitor, ARB, or some people now start with ARNI, you start with beta blocker, right? You do vaccination, you probably will require diuretic. So this is guideline directed medical therapy. Now suppose with symptoms still patient gets symptomatic, then what you do? So basically you increase the dose of these drugs, so you go towards the top dose. But one thing to remember, if you want to increase the beta blocker dose, depending on heart rate, always increase the diuretic dose. Otherwise, as I said, symptoms will increase with beta blockers. So once you are increasing the beta blocker dose, you simultaneously increase the diuretic dose. So here what we did was 5 mg bisoprolol was being given, so made to 10. Ramipril 2.5 was given 5, and Lasix was added because beta blocker was increased. Then what happened? If there are persistence of symptoms, again you could go a bit higher. Bisoprolol, of course, you cannot go more. This is the problem with bisoprolol. Lowest dose is 2.5, highest dose is 10. With metoprolol, start with 12.5, 25, 50, 100, 200, and more. You can go 400. So this much, but depending on heart rate. Somebody has got 32, then you start to make it. So depending on heart rate, you can up titrate metoprolol. Atenolol also you can go to 200, and other drugs. Atenolol of course is not prescribed. Why? It is not cardiac specific beta blocker. You use cardiac specific beta blockers. Atenolol you do not use. The mortality benefit in heart failure with beta blocker, or not mortality benefit, but the benefit in ischemia and stroke rate were seen with cardio specific beta blockers, not atenolol. So that's why atenolol is completely gone now. So obviously you increase this dose, but if you are increasing beta blocker, you add diuretic. But if the symptoms persist, then you add mineralocorticoid receptor antagonist, as I told you. So you add mineralocorticoid receptor antagonist. So as I said, Ramipril 10 was made 10, but bisoprolol can't increase because anyway this is the top dose, but it was also causing bradycardia and one first degree heart block. So eplerenone was also started 50 milligram, but symptoms did not improve. Then what you do? You have gone to the highest top dose. Top dose of bisoprolol is 10. Top dose is Ramipril is 10 mostly. Enalapril is 20. Ramipril is 10. So you have practically approached the top dose now. So what do you do now? What to do? So one is, as I said, there is some data that if ACE inhibitors, ARNI is better than ACE inhibitor. So now you can switch over from ACE inhibitor to, you can look at ARNI, right? Also now what you can do is you can see whether the symptoms are not improving patients. So can we put on CRTD or ICD? Anyway you should put if ejection fraction is low, but CRT you can start thinking, especially if QRS is more than 150 or LBB morphology. So you put a device called CRT. So ARNI was started, but as I said, very important, suppose you give ARNI with, on the first day, day 1, with Ramipril 10 mg on, suppose you start ARNI. ARNI is what, Vimada, I don't know what is available here, normally the trade name is Vimada, but sacubitril valsartan,
Sigma
Sidmus also, yes, lupin Sidmus, and I think one more Asmarda or something like that. But suppose you start this, so suppose you want to stop ACE inhibitor, can you do it on the same day? Why? You have to give a washout for ACE inhibitor. Why? Why? Anybody? You should know. बताओ फिर. Because there are incidences of severe hypotension because of allergic reaction. So it can happen that if you give ARNI, there were in the original trial which he is not naming, there were some cases which developed severe hypotension because of interaction between these two drugs. So they have to, you have to give a gap of at least 48 hours, 36 hours before you can start the new thing. Okay, remember this, because sometimes this can happen and then it's a problem. Then obviously this new drug dapagliflozin was started 5 milligram, increased to 10 milligram. But patient developed another episode of heart failure despite all that. So this is the guideline directed medical therapy which we have followed, but still patient had decompensated heart failure. Next slide. Now what we see, we have 3 hospitalizations. NT-proBNP was increased despite best optimal medical therapy and high dose Lasix. Patient is still getting into these problems. Vitals at this point was 120/80, heart rate 60, which shows that you cannot increase beta blocker anymore. Saturation is okay. ECG had these atrial, what we already thought had some ectopics also. X-ray, the fresh X-ray showed evidence of pulmonary edema. NT-proBNP, the second value is again you can see is high. Ejection fraction is same 26% with lot of problems. So now what to do? Now what to do? We have finished our drug therapy, we have finished our device therapy, right? Patient has been given everything, but patient continues to have symptoms. Actually device therapy could not be given because QRS was not prolonged, if you remember. So there is no benefit of putting a CRTD. You could put ICD, but CRTD no benefit because QRS not prolonged. So I think this patient has progressive heart failure. You have done everything that you can. So now the options remaining is cardiac transplantation. That is the best therapy for this patient. But obviously transplant donors are not easily available, that facility is not easily available. So there is something called ventricular assist device that you can temporarily put till either transplantation happens or till the patient lives basically. So that you can do, but this patient refused both assist device, because assist device, how much does it cost? Suppose you want to put a ventricular assist device, what is the cost? 6 lakhs. 6 lakhs is ECMO. ECMO is about 5 lakhs, 6 lakhs, but ECMO will last only 2 weeks. ECMO will not last 2 weeks. Impella will last even less. Impella is also 15 lakhs, but Impella will also last maybe week, 10 days. You have to remove it after that. ECMO also you have to remove after maybe 2 weeks. So the only relatively permanent solution is ventricular assist device. And what is the cost of ventricular assist device? Anybody, any guess? 6 lakhs तो नहीं है, और बताओ. 80 lakhs. So obviously people cannot afford, and transplant is also not available. So anyway, patient was told the cost of ventricular assist, the patient refused. So then what to do now? Do we leave him to go? So next please. अभी एक special है case, सब में नहीं होता, but what we thought was कि ultimately it is, what happens is with heart failure, the need for diuretic goes up and down, and that is why symptoms go up and down. Actually decompensation is what? Sudden congestion. So if you can measure the LA pressure, and according to LA pressure you can give your diuretic. What LA pressure we want to keep? We want to keep LA pressure less than 14. Yes, we told that day also, no? So we want to keep it less than 14. So if it goes less than 14, then we just hold on to diuretic. If it increases, then we give more diuretic. So if we can do LA monitoring by some device, So you can actually adjust the dose of diuretic according to that, and that can prevent a lot of hospitalizations. But that LA device is not available in India. We got this device from abroad, USA, and we put this one LA device, and then through that we monitored, and actually this helped the patient. And this device is Nims, which is kind of recommended, but then it's a very expensive device and you have to get, but it's not as expensive as VAD. VAD is even more expensive. Next. So patient had a good adherence, CRT जो था वो भी we ultimately put, क्योंकि over a period of time was LV dilatation happened, so ज़्यादा LV dilatation QRS prolong हो गया, शुरू में नहीं था, बाद में QRS prolong हो गया, तो CRT device भी डाल दिया था and it was optimized. But with diuretic patient did well. Ultimately 6 months maybe patient was doing well, so that was the patient was just maintained with proper diuretic therapy, putting this LA device. This is not a routine thing, I just told you because to make you think how we should go about it. Next. So what did we learn from this case? Obviously guideline directed medical therapy is cornerstone for heart failure therapy. The aim is to reach target dose and initiate one therapy after other as the disease progresses or the failure progresses, as we did in this case, as you might have noticed. If there is a recurrent acute decompensated heart failure, then we have to start thinking of heart transplantation, and in between to bridge maybe ventricular assist device if patient can afford. But this, as I said, is an interesting option which we tried in this particular case and we were good with it, but this is not a regular thing, I have to tell you. Next. So what is the treatment algorithm? Now I want to talk with you the treatment algorithm of acute decompensated heart failure. So of course first is propping up head because patient is in pulmonary edema, then giving proper oxygen. Depending on how much oxygenation is there, you can give by nasal prongs or you can use NIV depending on what. Morphine. Does morphine help in pulmonary edema?
Yes.
How?
It is between pulmonary and systemic circulation. That's why.
So first is reducing anxiety. That is one, because anxiety can cause tachycardia, that can cause further worsening. It can reduce anxiety. It can reduce pain, discomfort. So that can also lead to sympathetic blockade or reduction of sympathetic tone. And then finally what he is saying. That is why in acute MI also people use morphine. So specifically morphine because of these three things. Then obviously you have to give, because it's already state of congestion, you have to give furosemide to decongest. Then next thing is to use ACE inhibitor, ARBs. You don't start beta blocker at this stage. Why? Because it will cause worsening of symptoms unless you decongest the patient and then you start beta blockers. So at this stage you start ACE inhibitor, ARBs. You can give nitrates, as I said, vasodilators to acutely manage decompensated heart failure. You could consider giving digoxin, and then I put it like this because this is a bit controversial. But sometimes life-saving, something very serious problem, other things not working, you may start digoxin also. Then cardiac assist device is something that is very important. When you think of endomyocardial biopsy, then immunosuppressives or immunocardiac biopsy, if you are thinking of myocarditis as a cause of heart failure, acute decompensated heart failure is the first case. There you can think of these possibilities. If there is lot of fluid, you cannot remove by diuretics. So what is the best diuretic therapy? You from oral you increase the dose. Which is the most potent diuretic? Loop diuretic. Loop diuretic is more potent than thiazide, indapamide, any other diuretic, and this what you use for Damox. So loop diuretic is the most potent diuretic. You go to top oral dose of loop diuretic. If that does not help, then what you do? You go to IV diuretic, furosemide. If that does not work, then what you do? You give infusion of diuretic. If that does not work, then what you do? You add another diuretic like thiazide, because they act at different parts, no? The loop diuretic acts as at descending, and thiazides act at. So they act at different parts, so they can their addition can be additive. So sometimes you can combine the diuretics and then have more diuretic efficacy. But if it still does not work, then what you do? You start vasodilators like nitrates. So that can help congest. If it still does not work, then what you do? You do ultrafiltration. So this is the last step in trying to decongest the patient. So ultimately you go for dialysis and do ultrafiltration, remove fluid. So that is the thing. Then if there is something surgical, obviously you treat it surgically. You could do coronary artery disease bypass surgery. If it's valve, then you do valve lesions. Sometimes you could do what we did here, MR surgery or something to mitral valve repair to decrease the size. If there is a ventricular aneurysm, obviously you cut it. If it is VSD, then obviously you repair it. But still does not work, then you have to go for VAD. First VAD you can do if you think only a few days VAD is required, then you can do ECMO. But if you give ECMO for 3 days altogether, what happens is that LV pressure suddenly rises. I will go into detail sometime. So you have to put another VAD in LV to decongest, because ECMO is mostly right sided. So you do only ECMO, then what happens is over a period of time LV and diastolic pressure rises. So you will have to do something to decongest LV also after 2 days. So you may have to put another device, maybe Impella device, or maybe for long term you could put a ventricular assist device. So something like that. So that is what I was saying. And finally you have to go for transplantation. So I think, friends, I think we end here with this case. I know it gets a bit long, but I thought it's like interactive, just discuss things.